Thank you very much, Dave. Good morning, everybody. Uh, wherever you are, most of you will be in South Africa, but there are probably even some outside of our borders. So thank you for joining us in this year's Child Health Priorities Association conference. My name is Ute Feucht. I'm the chairperson of the Child Health Priorities Association. And the rest of the exec, who you will be seeing in the next 2 days, is Dave Leroux, Haroon Saluji, Laurie Lake, Nzipho Mosakwa, Ntodeni Rabulubulu, and Notando Mbata. So thank you for joining us. We've put a lot of work and thought into putting the program together for this year's conference. As you can see, the theme is child health from crisis mode to solution mode. So who are we as a Child Health Priorities Association? We are a South African-based organization concerned with child health matters. So it's a multidisciplinary organization, a multi-stakeholder. It's not linked to one specific group in terms of the job description, and it's really and it's not even only linked to healthcare workers. So it's really people in our country who are concerned about our children and the health of our children. The conference goal is knowledge sharing, but also networking, and and this is where you will all need to really contribute for us, because obviously we know a virtual conference is not as nice as networking in person. But on the other hand, it gives us the opportunity to actually come together in a format that is green. We didn't spend too much climate points on attending. So we need to, and it's also accessible wherever you are in the country. Yeah, so again, we know it's nicer to look people in the eyes, but let's make the most of the virtual format. It has also meant that we've had lots of registrations. We have 237 registrations, which is just fantastic. This is certainly more than what the registrations would have been if we were in person. We have planned 2 days of deliberations with multiple sessions you would have seen on the program. So we're kicking off this morning with a session on infant and child mortality, then a session on care coordination. Then we have severe acute malnutrition and violence against women and children. The second day is focusing on the South African child health workforce, migrant, refugee, and undocumented children, innovations in child health, and then we also have received excellent research abstracts. So the day tomorrow will be ended by the presentation of the research abstracts. And then please don't forget, the AGM is tomorrow at 12 o'clock. This is not our association. Well, it's not my association. It's not the ExCo's association. It is our collective association. And once a year, we have a meeting where we discuss what we're doing, where we're going, what our focus areas are. And so please join in the AGM tomorrow at 12. You can join us with your lunch in front of you. Come listen. We need a quorum, otherwise we can't move forward as an association. But it's not only that; it's really for us to discuss where we want to go. So that brings us to the first session. Let's try and be in the moment. That's the risk of the virtual conferences, that we end up multitasking. If we're in a real life in-person conference, we switch off our phones. We tell everybody we're not there for the 2 days. We're on conference. The risk with the virtual conference, we all know. We get distracted. Our phone rings. We multitask. So let's try and be in the moment. Let's make the most of it, and tell people, this, I am out of office for at least for the hours of the conference sessions. You can go and answer your emails and your messages in the break times. So please ask lots of questions, engage, let's have discussions. You will see that some of the sessions were really planned as panel discussions or also lots of question and answer time. The idea is for us to engage because otherwise and some of the sessions will be really short if we don't get engagement from the floor. So please feel free to join us in the discussions. So that brings me to declaring this conference as opened, and I'm handing over to Dave Leroux for the first session on infant and child mortality. Thank you. Over to you, Dave.
Brilliant. Thanks so much. Just to mention, there is a Q&A box which is coming through to the hosts and panelists, so we can see your questions. I think there is also a chat. If somebody wants to put something in the chat just to say how's it, then we can all see check that that's working. And I'm watching the Q&A box just to see if there's anything else that comes through. We will direct the questions to the panelists. Okay, so this session we're talking about infant and child mortality and what we're doing about that. And just want to share this. My kids say that boomers and Gen Xers mustn't try to use memes because it's not as cool as you think it is. I think they're wrong. I think Gen Xers should use memes. I think it's every bit as cool as we think it is. I don't want to be the dog sitting in the house and says this is fine if it's not fine. If there's a problem, we need to know about it. And there's been a lot of concern that we are infant, child, neonatal mortality in this country is actually not fine. And I'm worried that we're sitting in a house and there's flames all around us. And somebody needs to actually say this is not okay. So with that, it gives me great pleasure to hand over to our keynote speaker for this session, Prof. Ziyaad Dangor from Wits Vida, who's going to be talking to us about the CHAMPS mortality trends and innovations, unpacking some of the amazing work that's been done with minimal invasive tissue sampling and some of the work they're doing in CHAMPS. Ziyaad, thank you so much for joining us today. We really look forward to what you have to share with us and talk us through where we're going with mortality trends and innovations. Over to you. Thanks.
Dave, thanks so much. And thanks to the organizing committee for welcoming me to do this plenary talk. I'm just going to share and just tell me if all is good technically. Is it all good?
Looks perfect. Thank you.
Okay, I'm going to turn off my camera just for now, and then I'll turn it back on at the end for questions. So good morning, everyone, and again, a huge thanks to the organizing committee. Today, I'm going to be talking to you about some of the data that we've aggregated over the last 10 years in terms of child mortality in South Africa, and particularly from the Johannesburg Soweto site. And the title of the talk is From Evidence to Intelligent, and this is some of the trends, and hoping to talk about some of the innovative strategies that we're thinking about going forward. So most of you are familiar with this kind of graphic representation where we see that child mortality rates in high-income countries have come down much more rapidly over the last sort of century. And we only start seeing declines in low and middle income countries in the more recent decades, which is unfortunate and again talks to the inequity that we see between the high income and low middle income settings. But the good thing on the positive side is that child mortality rates are coming down, under 5 mortality rates are coming down in countries in Africa and Asia as well. And when we look at the major causes of death globally, we also see declines across pretty much all the different conditions over the last 3 or 4 decades, which showed high rates in the 1980s, and then rates that have come down for pretty much most of the significant conditions, including malaria, LRTIs, diarrheal disease, where we've seen major interventions like vaccination in South Africa, prevention of mother-to-child transmission, etc. really showing improvements in reducing child mortality. Now, this is the IHME data from 2024, and I don't want to go into the detail of this map, but I just want to highlight the difference in the underlying conditions that are causing under 5 mortality. And you can see that where South Africa sits, preterm birth is the leading cause of mortality. And I'm going to show you some of this data coming through in the data from Soweto. So to tell you more about CHAMPS, Child Health and Mortality Prevention Surveillance is a program that's being undertaken for the last 10 years in South Africa and 9 other countries. This is funded through the Gates Foundation, and it's really a project that's aimed to reducing child mortality, building local capacity, and using the data that we generate to change evidence-generated data to change practice and actionable items that we can do to reduce child mortality. So what this study does is essentially it has a huge community engagement startup and ongoing community engagement where there has to be buy-in from the communities to do a project like this. That's followed by surveillance to identify children who have passed away, including stillbirths, and then doing some sort of procedure on those babies to try to determine the cause of death. Now, when I talk about procedure, essentially what I'm talking about is in addition to collecting clinical information and verbal autopsies, we also do a number of sampling strategies. And we do this technique called minimally invasive tissue sampling, where we don't do a complete diagnostic autopsy, but rather we take core biopsies from a number of organs, including the liver, the lung, the brain. In the stillbirths, we also evaluate the placenta. And then in addition to that, we collect blood, CSF, and oral and nasal swabs, and stool or rectal swabs. And then we send this to the laboratory to undergo an array of testing from culture to molecular testing, including histopathological assessment of these tissues. And all this data then gets fed in right at the end to a panel of experts who sit around a table and work through what the cause of death could be. Now, these experts use the WHO classification for coding the cause of death. And as you all know, in part 1 of this frame, it's really to talk about the causal pathway. So what led to the death from the underlying cause right to the immediate cause, as well as noting any other significant conditions that contributed to death. And the whole point, like I said, is to really share this data with families to understand why their child has passed on, with communities in terms of what can we do better in terms of improving care, with health facilities, national public health agencies, and global institutions, again, to foster improvements in care and reduce mortality in children. So I'm going to first share a few slides on what the data shows from all the different sites. And this is a paper that was published in JAMA that really shows that in children 1 to 59 months, what you see is the most common underlying conditions are malnutrition, HIV, and not so much in our context, but malaria in those settings where malaria is endemic. And when you think about what are the immediate causes of death, it's still infection-related. Lower respiratory tract infections and sepsis are the leading immediate causes of death in children 1 to 59 months of age. And this is a very complex figure. It's one of these Sankey plots. And just to talk you through it very quickly, on the left-hand side, it shows the underlying condition. And on the right-hand side, it shows the immediate condition. You don't have to focus on the detail, but what I really want to show here is that as these colors you can see really go all over the place, it shows that underlying conditions can end up with an immediate condition that or multiple underlying conditions can end up with certain immediate conditions, and infective conditions like sepsis and LRTI seem to predominate. And when we look at the organisms causing these infections, again in children 1 to 59 months of age, we see that Klebsiella pneumonia and Streptococcus pneumonia, even though we've got extensive vaccine coverage in South Africa, in other sites as well, we see that these strep pneumonia still predominates in one of the leading causes of mortality from a bacterial point of view. And Klebsiella pneumonia is something that we really have to pay attention to, because that's also causing a large component of these infection-related causes of death. So let me share data from Soweto. So as the map implies, Soweto is in Johannesburg, Gauteng, and we don't cover the entire Soweto. We essentially cover these areas in red on the figure, which are portions of Soweto, and those portions make up about 200,000 population. So over the last 10 years, we've collected data on 1,500 children in terms of doing these autopsies. And what we've done is collected 700 neonates or enrolled 700 neonates into the study. Stillbirths, there were 460, and there were infant and child deaths as well. So from the stillbirths, what I'm now going to show is a series of tree maps. And essentially what these maps do is that all the colors should add up to 100%. And what you can see, the predominant causes of stillbirths are intrauterine hypoxia or asphyxia, or congenital infections. So 2/3 are from some sort of asphyxiated event. And I know you may say, but that's not a diagnosis and it's rather a mechanism. The problem with these is that often we're unable to give or pinpoint the diagnosis. But the other important component is 1/3 of them are from congenital infections. Now, which congenital infections? Let me blow up that pie graph and show you that group B strep, as expected, is the commonest organism causing these stillbirths, followed by E. coli. But what's really concerning is this 23% of syphilis-related stillbirths, which is significantly increased over the last few years of us doing surveillance in this site. Now, when we look at the main maternal condition, because often these stillbirths, the maternal condition would be the cause or the underlying problem here, we find that maternal hypertension stands out, or pregnancy-induced hypertension stands out as an underlying maternal factor contributing to stillbirths. Obviously, we see chorioamnionitis for those congenital infections as well. So the panel is then asked, do we think that these stillbirths are preventable? And in 40% of the time, the panel thought that it is preventable, and some of the preventability buckets included improved ANC, obstetric care, and health-seeking behavior. Now, this figure just shows what are we, in terms of our performance as South Africa, we're not really doing great when it comes to the stillbirth rate. As you can see, not much declines in stillbirth rate over the last 2 decades. And in comparison, when we look at this in comparison to the neonatal rate, we're doing a bit better. So let me tell you about some of the deaths that have occurred in neonates. If we again look at these 3 maps, and as highlighted by the IHME data, we're seeing that neonatal preterm complications account for 56% of the underlying cause of death in neonates that we have sampled as part of this study. And this is certainly worrying that such a large proportion of these neonatal deaths are from preterm-related complications. And when we look at the immediate cause, and this is no surprise, the immediate cause for these preterm babies that are in the ward would be then succumbing to some sort of hospital-acquired infection in the neonatal units. So again, the panel thought that this is preventable, and in 60% of the time, the panel thought that we could prevent these neonatal deaths. And amongst the most common preventability buckets would be to improve our infection prevention and control, which is very challenging, but that's an important bucket. And then improving antenatal and obstetric care would be some of the upstream factors to reduce prematurity in itself, therefore reducing crowding in the neonatal units from preterm babies and those that succumb to the infections. Infants going from 1 month to 12 months or just under 12 months, some of the data here, and as you can see from these 3 maps, you see much more heterogeneity now coming in, which is expected as the children get older. Neonatal preterm complications still sort of carry into this period of infancy, but then you start seeing children with congenital infections who may have survived the initial neonatal period succumbing to some sort of cause or being the underlying cause and succumbing or demising because of these congenital infections. We also see things like malnutrition, HIV becoming important underlying factors. But again, when we look at the immediate cause of death in all these underlying causes, it comes back to infective causes. And this is certainly worrying that children in the first month of life, the immediate cause of death is infection related. Preventability, again, 6 out of 10 times we can prevent this. Here, the preventability buckets include health-seeking behavior, health education, improving HIV prevention control, and quality of care and clinical management. So just to highlight the organisms that are causing death, these are the top 10 organisms in neonates and in pediatrics. And what you can see is that in the neonates, the top 2 organisms are Sithembile Dlamini-Nqeketo and Klebsiella pneumoniae. This is certainly worrying that these 2 organisms by far exceed the next organism, which is number 3 on the list, which is group B strep. And what we would have seen 20 years ago, where group B strep is the commonest cause of neonatal sepsis, we're now seeing these hospital-acquired infections really predominating. In children 1 to 11 months, we then see a predominance of Klebsiella pneumonia. And one may ask then the question is, in these 1 to 11 months, are those babies still, some of them being still in the neonatal unit? And the next slide really, what I was trying to do in this slide is show the distribution of these pathogens on the left-hand side, showing it by their birth weight, or which we use as a surrogate marker for those preterm babies. So you can see that these 2 predominant organisms are particularly devastating in those babies that are low birth weight, and 87% of the ABAMANIs occurring in these low birth weight babies, as well as 82% of the Klebsiella pneumonias. And on the right-hand side, what I'm showing is babies that are still in the neonatal unit at the time of death versus babies who have left the neonatal unit. And here is no surprise, ABAMANI is the predominant pathogen for babies who never left the neonatal unit, telling us that thankfully there's not much ABAMANI happening in the community. But when you look at Klebsiella, and I just want to draw your attention to this, is 1/3 of the Klebsiella cases are in babies who have left the neonatal unit or not admitted to the neonatal unit, and showing that there is an increasing community burden of Klebsiella pneumonia infections. So lastly, in the older children, just to show you that in older children, we even more heterogeneity in the tree map, but I want to highlight important things like burns. 20% of the childhood deaths that occurred in Soweto, the underlying problem was burns, which is very, very worrying that so many children, and these are all hot water burns, and we're working at the moment with the pediatric surgeons to try to reduce some of this risk by sharing information as well as educating the community. Poisoning is another thing that has been flagged in the media in South Africa this year, and thankfully that there's been a recommendation to ban tuberphos in South Africa, which is great. And then we also see the sort of more heterogeneous conditions as the underlying cause. Immediate causes, again, in children up to 5 years, infection-related causes still seem to predominate. It's still quite worrying that a lot of these children who come in with underlying causes then succumb to some sort of infection. In terms of preventability, again, the panel thought 60% was preventable. Here, a lot more around health education and improving the access to care. So in my last few slides, as I close off this talk, is really to say, what do we want to do differently going forward? What are the kind of smarter systems? How can we innovate mortality surveillance for the future? And I really want to introduce you to some of the work that's been done around this. So firstly, we know that in South Africa and lots of other low and middle income countries, the tool used most frequently to determine cause of death is a verbal autopsy. We know it's low cost, but extremely imprecise. They estimate that 1 out of every 2 verbal autopsies would be imprecise. And therefore, we cannot use verbal autopsy as a measure to determine what the cause of death is if we want to go into the future with a more granular understanding. As I've explained, we've used this minimally invasive tissue sampling as an alternative to a complete diagnostic autopsy. But as you can see from the right-hand side, these minimally invasive tissue sampling per person is actually quite expensive. It can be anywhere between $600 to $1,000 with the lab work as well as the clinical staff required to undertake these testing. So what we're sitting with is a kind of situation where the more accuracy we require, the more invasive we need to be in terms of autopsy. And we're balancing accuracy and granularity with cost, expertise, time, and also acceptability from the community where it is more frowned upon to do complete diagnostic autopsies. Now, given that there's been so much in the space of AI and there's been so much in terms of these large language models, can we make things easier for ourselves rather than make things more challenging from a South African perspective? So can we achieve accurate granular understanding of mortality in broader geographic regions, and how do we do this? So the one is obviously we want to streamline inefficiencies. So can we automate or optimize the verbal autopsies or the clinical abstraction workflows? Can we look at compensating for this limited electronic health record that we have in South Africa by using pattern recognition, seasonality trends, and outbreak data, based solely because we don't have this data routinely captured? Can we guide post-mortem investigations so that we don't test, as we've done as part of the CHAMPS study, every organ? We only test select organs or those organs that give us the most accuracy and the most yield. And can we have AI-driven or supported panels to determine causes of death with adequate training? These large language models should be able to give a cause of death that's very close to what a human being is able to do. So the role of AI is far-reaching, and this is some of the slides shared by the Gates Foundation. And what we see is that you can improve locals, or you can use AI to support or enhance local surveillance data. It can determine cause of death. But also in South Africa, we really want to look at it too. How does it able to or assist us in terms of drawing information from hospital records? How does it assist us in terms of language translation? Can it have speaker recognition where we can do these verbal autopsies much more seamlessly? Can it give diagnostic recommendations? Would it assist with language translators? And colleagues, these are already on the market. We're already seeing these evolving in the clinical space. So what the Gates Foundation is aiming to do, and this is a meeting that's been set up for next week, is they're aiming to develop a cause of death assistant, which they call Encoder. And essentially what they aim to do is to be able to facilitate in the interview process versus a clinician note process. Can it assist both the clinician in either of these scenarios to be able to come to a cause of death more clearly? So what is the information required to get to that? And number two is, what is the investigations required to enhance the granularity of the cause of death? And the kind of picture would be, at a glance, this is what you'd be looking at, is there's some software tool, and this software tool during an interview prompts a certain amount of questions. It also draws from the surveillance data, for example, in our context from the NICD, it would have the current outbreak profiles. And then it incorporates this with the clinical information and then makes some recommendations in terms of what could be the cause of death and the certainty around that cause of death, but also suggest what testing would be required to improve the understanding of the cause of death. So where do we want to go as South Africa? And this is my open plea to colleagues on this call. I'm really hoping that there is some path to implementation over the next 2 years. And for this part, the implementation, it would be really starting with identifying the partners. And I think the Department of Health is crucial in this relationship, NICD, MRC, etc. Then identifying potential pilot sites where we can be exploring these options. Do we have established sites that can do this? Do we have sites that have electronic health records? Do we need to set up new sentinel sites so that we can determine cause of death more accurately and generalizably across South Africa? And lastly, do we want to then develop this implementation and research agenda over the next 2 years? I'm really looking to all of you to be part of this process. And if you're keen, to please reach out and we can talk further about this. So lastly, just to say, these are the QR codes. If you want to see the more detailed data, the first QR code gives the South African data. The second QR code is across the entire CHAMPS network. So I'll hand back to the chair, Dave. Thanks so much. I think I've just finished within time and happy to take any questions.
Yeah, that's brilliant. Thank you so much. That really is amazing. So much of that data that you've done from the MITS is immediately applicable to a context outside of where the research was done. How soon will the coder be, at the moment, obviously a research tool? When will that be applicable outside, and when will those results be able to be applied in the rest of the country?
No, thanks, Dave, for that question. So this is a very exciting time in terms of this cause of death assistant, and the Gates Foundation has provided a number of awards to multiple institutions, both in Africa, Asia, as well as more in high-income settings. And essentially what these partners are going to be doing is developing this roadmap. So I know there are already a number of computer science groups that are working on these algorithms. There's a number of groups working in terms of improving these translational tools as well as these data abstraction tools. And we plan a meeting next week. South Africa has been identified as one of the potential pilot sites to roll this out. And that's why I'm quite excited about this and so opportune to be invited to present today, because I feel that the colleagues on this meeting and more broadly around the colleagues that have been involved in child health priorities would be at the forefront of some of these discussions, especially as we take this forward. And I'm hoping the timeline, Dave, has been set for the next 24 months to get some sort of first round pilot being undertaken.
That's brilliant. Absolutely amazing. It's really exciting work. Haroon, do you want to go ahead, ask?
Thank you. So, Ziyaad, I think the work is obviously exceptional. To have cause of death data to the degree for 1,500 children is fantastic. So your main responsibility as CHAMPS is to generate the data. It's not necessarily to respond to it. But my question follows on Dave. So two questions. One, within the context of Soweto, what kind of interventions have you enabled to respond to this data? And the bigger question is, again, your role is mainly to generate the data, but how would you see in the broader South African context, we using this data? Clearly, you will continue to innovate in how this kind of data is generated. You said it's very expensive, but how would you like this data to be used more widely in the South African context? Over.
Alan, thanks so much for those questions. So in terms of the CHAMPS mandate, it's been to collect this high level or high quality data, as you correctly pointed out. One of the more softer objectives of the CHAMPS program is to say what kind of projects can you pilot in a local setting to see if you can make some sort of change. But the core objective over the next 5 years from the CHAMPS study is to widely disseminate this data so that it can encourage partnerships, both within government as well as outside government, for stakeholders to come through and prioritize certain interventions based on this data. So it's really taking this data into action. And as you correctly pointed out, CHAMPS is not funded to do this as an implementation program. So it's really what the Gates Foundation is looking for partnerships within country and outside country to drive some of these initiatives. On a smaller scale, what has happened is that if initiatives were very bold and there was opportunities to discuss with government, then some of these initiatives have gone forward. As an example, for South Africa, the obstetricians that sit on the Decode panel were quite surprised that aspirin was not being prescribed to pregnant women by the antenatal care services in South Africa, simply because the midwives were not allowed to prescribe a drug which is not even a high schedule drug like aspirin. And because of that, that recommendation was taken from the obstetricians on the panel to the Department of Health, who then released a instruction that midwives can then prescribe aspirin at antenatal clinics, and these mothers don't have to be referred upstream or to the obstetricians for prescription. So that's it was very simple to do because we were not introducing anything new. Another example in Ethiopia, for example, they saw a number of neural tube defects occurring in the population. And with their Department of Health, they've been able to fortify the salt with folate. So those are big initiatives. Smaller initiatives and more locally is really trying to improve some of the systems. And I don't know, I mean, this is challenging. It's really challenging. I think we have to work together. A significant joint effort is required to tackle some of these issues. And that's what we're hoping to do over the next few months.
That's brilliant. Thank you. There are two questions in the chat about Acineta and access to colistin. I think that's going to become an antimicrobial stewardship discussion, and how do we handle our resources when it's a difficult to treat infection. So there's another question. Cause of death for stillbirths, where you probably still need to sample the placenta. Did you encounter any parental resistance to this, even if minimally invasive, given cultural beliefs and practices? Do you want to just talk to that question?
So no, thanks for that, Dave. So some of the hospitals in Johannesburg have instituted that all stillbirths, the placenta is routinely collected and submitted to the NHLS for processing. And that has not come from us. That's come from the Department of Obstetrics directly. We do have opportunities to get some of the core biopsies of those placentas and to also have a look at those placentas, because the NHLS supports our histology program as well. So the question about whether it was culturally accepted, because these stillbirths routinely are now, the placentas are being collected, I don't think there's been much resistance to that because of the routine nature of that. But in terms of just the study in general, I just want to highlight that we initially thought when CHAMPS started 10 years ago that most parents would not be too happy about doing even minimally invasive tissue sampling. But what we found that in Soweto, and this is also happening across the other sites in Africa, is that the consent rate is above 80%. And that did surprise us, to be very honest. And I think it's partly because there's this need to, or want from the parents to have a bit more information around the death. And they openly, declare when we give them the feedback that they feel that this is giving them some sort of closure. So I think that's a positive. We also have counselors that do the consenting process. So they provide the bereavement counseling following the death of the loved one, I think, which has also been really well received by the community.
That's brilliant. Ziyaad, thank you so much. That really is insightful. And as Arina is saying, just really, really valuable data that we're going to be able to apply. Please, can you put a website in the chat so that folks are able to look at some of the work that you're doing? And then we'll make the recording available for folks to go back and look at the slides in a bit more detail. Okay, wonderful. That's magic. Thank you so much. I really appreciate your time and investment and sharing that data with us. So our next speaker, we're looking at some trends and some interventions. Jaco Murray is a pediatrician at Paarl Hospital. He's been involved with the Child PIP program for many years, and he's helping out in the Western Cape and doing a lot of some of the national collation. Jaco, thank you for talking to us today. Please, will you unpack your big topic of under 5 mortality and interventions and trends? Over to you.
Good morning, everyone, and thank you, Dave, for the opportunity. Ziyaad, thank you for the wonderful talk. Lots of good points that you made. And I ask that you just unshare your screen because I can't share from my side. There we go. Okay. Good. Yeah, so thank you for the opportunity to present today. I think I'm also going to switch off my camera, if that is okay, just for the presentation, just for data. So I'm going to talk about the under 5 mortality in South Africa, where we are standing right now, why the recent trends are so concerning, but most importantly, I will focus on the practical evidence-based interventions that we can put in place immediately to reverse it. So if we look at data, let me just see. Okay. If you look at child mortality data, and Ziyaad also made a good point about the importance of mortality data. We basically have several sources, but each has its own limitations. The Stats SA vital registration gives us population-based estimates, but it's hampered by the long delays and incomplete birth and death registrations. Then we have the DHIS that captures facility deaths, but it lacks detailed audits, and it also does not include outside facility deaths. CHPA gives us the best facility death audits, but it's been struggling with data capturing challenges and also software upgrades. There is some child death reviews that provide invaluable insights into non-natural deaths, but unfortunately that's only in a few provinces and also sporadically, like the CHAMPS project. Then we have the household surveys that help us to understand the social determinants of health, but it does not give us specific mortality data. So as a country, we still face major gaps, like the underreporting, especially the outside facility deaths and in rural areas. We have delayed registration, poor cause of death certification, and then there's big discrepancies between some of our sources. So we need to move away from paper-based systems and really strengthen our civil registration and integrating our data systems nationally, and that remains an urgent priority. So if we look at the trends in child mortality, and Ziyaad also showed you some slides, but over the last 2 decades, we've achieved remarkable progress. According to this slide from Stats SA mid-year population estimate for 2025, the under 5 mortality rate dropped from almost 80 per 1,000 live births in 2002 to around 26, 28 by the mid-2020s. This is largely due to the ARV rollout and the PMTCT program and the introduction of immunizations like the rotavirus and pneumococcal vaccines. But if you move and look closer at the last decade and then compare the Stats SA data to the UNICEF group data, which is a modeled estimate based on vital registration figures, then there is a discrepancy, especially in the under 5 mortality rate over the last few years. And this is likely due to the estimated modeling of unregistered deaths that is especially in the group from 1 year to 5 years of age. So although you can clearly see that there's a downward trend initially, both trends have a flattening of the curve between the years around 2019, 2020. And then there was a slight increase from 2020 to 2022, post-COVID, where there was an increase of deaths. And now if you look at our Sustainable Development Goal of 25 for the under 5, you can see that depending on which data set you look at, and there is a concern if you look at the Stats SA that there was quite a steep drop there, which is a big discrepancy from the UN IGME group that is have a more flatter curve and is stuck at around 34. So that's quite a big gap. So depending on which data source you use, the goal is either reachable or not. But either way, we know that momentum has been lost with the overall flatter curve. Concerning the neonatal mortality, it remains stubborn around 11 to 12 per 1,000 births, but we already have reached the Sustainable Development Goal of under 12. If we look at the annual rate of reduction, before 2020, we were consistently achieving an annual reduction of around 3 to 4%. But since the pandemic, the annual rate of reduction has plummeted. And you can see that around 2021, it actually turned negative for both the under 5 and the neonatal mortality rate, and that's according to the UNITME group. So we've gone from a steady process to stagnation and even reversal at the exact moment that we really need to accelerate towards this SDG target. And it also shows us that, you know, there were a few low-hanging fruit that has been picked, and now we have to work harder and smarter to get our mortality rates even lower. So if you look at this graph, that's the age category per year. When we look at the actual facility reported deaths in DHIS from 2020 to 2023, the age pattern is clear. Neonatal deaths are still the dominant group, and that's the dark blue and the green groups, and it makes it the majority of deaths each year. But I also want to highlight that you can see that there's a significant gap. If you look at the total deaths at around 18,000, it went up from 2022 to 2022 before it came down slightly in 2023. But if you look at the total deaths, it's below 18,000. And according to Stats SA, we have around 35,000 deaths annually based on previous estimates. So that means there's a huge gap between the DHIS deaths and the actual deaths. And that gap is mainly due to the outside facility deaths and the unregistered deaths. So these deaths are very poorly understood with significant lack of data not being captured either on CHPA or on DHIS. So if we look at the death age by province, we can see that Gauteng and KwaZulu-Natal have the highest absolute numbers because of their large birth cohorts. But when we look at rates per 1,000 live births, some of the smaller provinces actually have higher mortality rates. And it's important to note that when we look at mortality rates, it varies widely, and we need to target the support where the rates are the highest, not just where the numbers are the highest. So if we look at the proportion of deaths due to common causes, and this is also according to DHIS, then even if we have good data on good data on causes, it's really limited. So we can see here that neonatal problems like prematurity, birth asphyxia, and infection still make up the biggest share. But after the first month, that those big three that we all know too well, the diarrhea, pneumonia, and malnutrition, together cause almost half of the deaths that are not neonatal, and this is all non-neonatal deaths. So if we look at the interventions that we can put in place, then the Committee of Morbidity and Mortality in Children under 5 has recommendations divided into 6 categories that we can look into to see where the opportunities are to decrease child mortality. So I'll go through each one of them. And a big thank you to all my colleagues on this group. That's also some of them are in attendance here today as well. So if we look at malnutrition, malnutrition remains an underlying contributor in at least a third of deaths. We must do better at prevention, early detection, and the management of severe acute malnutrition. We need to train frontline staff properly in ETAT and how to manage severe acute malnutrition. We need to stop rotating trained nurses and doctors away from children's wards and pediatric services at the clinic. We need to focus on early detection and referral of SAM cases at primary healthcare clinic and make sure that the dietitian posts are filled and employed at primary healthcare level. Then we need to make sure that community health workers screen every child with a MOAC tape, so we find severe malnutrition cases even before complications occur. We need also to focus on the first 1,000 days, support breastfeeding, and teach mothers responsive caregiving. Also important is to work with other departments to fight poverty and hunger, and to scale up school and community feeding schemes, and also do regular SAM audits in every facility so we can keep on improving. If we look at deaths outside health facilities, we know that too many still die at home or on the way to the clinic or hospital, and we can stop most of these deaths if we can strengthen the community and primary healthcare service management of common childhood illnesses. So what are the things that we can do? So at district level, use ETAT properly, make sure everyone is trained, have a clear referral paths, and make sure that ambulance services are equipped, trained, and fully functional. In the clinics, make sure that IMCI is fully implemented, have oral rehydration corners ready, and get pulse oximetry meters. Concerning HIV and TB care, make sure that it's integrated care. Start ART fast, give TB preventive therapy, and improve the adherence support to families to make sure that every child gets the treatment they must get. Then we need to train the community health workers to focus on child health and to spot danger signs and act accordingly. We need to teach all the caregivers on the danger signs, and the Road to Health booklet can be used for that. And then also we can work with traditional healers in the rural communities where they also play a big role. So if we do these things, far fewer children will reach hospital in a critical state. Okay, so the health service itself must also be more responsive and accessible. So what are the things that we can do? We need to improve the ambulance services so transfers are fast and safe, especially in more rural districts. We need to link newborns to a primary health clinic before they even leave the maternity unit. We need to open clinics longer hours over weekends, and many working parents can't come during the week. And if the clinic is closed when the mother needs it, it's the same as no clinic at all. So if we move to non-natural deaths, injuries, burns, road crashes, and poisoning and drowning are one of the top killers of the neonatal period and is rising. Every single one of these deaths can be prevented if we could create safe home and social environments for children. So what are the things that we should do? So first we should start with awareness, and that is to teach expectant mothers about safe home environments. And also focus on information campaigns, especially burns awareness and concern, especially in winter. And then we need to give community health workers an easy home safe checklist to use at every visit, to check things like moving the paraffin, hot water, and poisons out of the reach of children, to use safe heaters, and also to use safe stoves safely. So these small changes can make really big differences. So if you move to road safety, we know that it's still a big cause of death in South Africa. The solutions are that we should teach every parent about childcare seats, and we should look at innovative ways to bring down the costs of these seats and to make it more accessible and affordable. And we need to work with the community safety on things like walking buses for school kids, and also safe pedestrian crossings, especially around ECDs and schools. We need to get the municipalities to stop illegal electricity connections that can cause fires or electrical fatalities. We need to push the Department of Transport to enforce the road safety rules properly. And then we also have a strong national policy, and the National Child Care and Protection Policy of 2019, which is really excellent. But we need to look at implementation and enforcing the policy. So yeah, I think the big message is that injuries are not bad luck. They follow patterns, and if we can identify that, we can stop them. So unreported deaths is a big problem. Many children die without anyone.
Sorry, Jaco, can you try and wrap up in the next minute or two?
Yes, let me someone goes straight to that. So basically unreported deaths, it's about improving the registration, especially working with the Department of Home Affairs. And then pre-hospital mobile factors is very important. Again, we should look at danger signs, and then we should also strengthen the link between the community structures and our facilities, so that they know the referral pathways and where to go. If we look at the hospital factors, we should make sure that proper triage is in place, we should enforce the early warning scores on every ward so that no child crashes without us knowing. We should do daily ward rounds and send out outreach teams from the bigger hospitals to support the junior doctors and cosmos at clinic at district levels. And then training is very important, especially with ETAT. And then resources for acutely sick children. We should make sure that we have the resources to look after acutely sick children. And the aim is to have 2 functional high care beds in every hospital where there is a children's ward that can provide especially oxygen and CPAP. So what is the main message? I think the way forward is that we really need to do the basics better. We need to do it faster, and we need to do it everywhere, especially in the rural districts. We need to fix our data so we can see the real picture. Again, especially the outside facility deaths. And then child PIP need all the support and strengthening that we can give it. And then we need to show leadership and make these changes happening now. And every single child we lose is one too many. And it's us here on this group, in this meeting, that is going to make the change and take this further. Thanks, Dave.
Jaco, that's amazing. That's brilliant. When will the comic report be released? Is that close to being public?
Yeah, it's just switch on my video. Yeah, it's I think it should be available very soon, definitely by the end of the year.
Okay, brilliant. We've been waiting for the next comic report for ages, and it's great that it's coming. And the 6 areas are absolutely critical. I'm astonished that we know so little about the deaths, out of facility deaths. Half of them are not being captured on DHAS. Amazing. There are a couple of questions in the chat and the Q&A. Maybe if you could just answer those. We're going to move on to the next presentation. Is Dr. Arina van der Bijl from the Free State talking about some of the neonatal deaths. And Jaco is going to address some of the questions in the Q&A in the chat. Arina, thank you so much for joining us and sharing this data. Sorry to put you under pressure. The clock is ticking. So yeah, over to you. Take it away.
Fantastic. Sorry about that. So thank you for the opportunity to present an update on the neonatal mortality trends based on our Saving Babies report from 2020 to 2023. I'm a neonatologist working in the Free State and currently also serving on the NPEMCO committee, which is how I landed up here. So as we heard, the SDG 3, all countries should aim to prevent our childhood deaths by 2030, and this includes decreasing the neonatal mortality rate to less than 12 per 1,000 births. And although South Africa has made great strides in decreasing the under 5 mortality, of which, as we've heard, this has not been true for the neonatal death rate. So there's a persistent gap in and lack of progress in this area. So although WHO data suggests that we are reaching this target, it doesn't fully reflect the lived experience that we have, especially in the public sector neonatal units, and the burden remains substantial, and there's lots of variability across provinces, districts, and also different levels of care. Interestingly, there has been a decline in the number of births observed across all provinces over the last few years, but this trend has not really translated in our clinical pressure. We still, especially in the Free State, in the neonatal units where I work, we're consistently busy and remain overcrowded. As expected, the declining birth numbers have also led to a decrease in the number of stillbirths and neonatal deaths, as you can see in the graph. But when you look at the various mortality rates, they have remained stagnant over the last few years. And currently, the neonatal mortality rate in 2023 was 13.2 per 1,000 live births. And of note, 75% of those deaths occur in the first 7 days of life. This data is also then in keeping with the District Health Barometer report, also based on DHIS data, with the neonatal mortality rate seemingly to be on an upward trend. Comparing provincial data with the South African average in red, you can see that there are clearly discrepancies between provinces, with a neonate born in the Free State having twice the relative risk of dying compared to a newborn in the Western Cape. And if we compare these bar graphs from the District Health report, you can see that we cannot be complacent. It seems that neonatal mortality is actually on an upward rise. You can also appreciate on the map, maybe you can quickly check your district. If you're in purple, you're doing well, but there are some alarming areas going into the orange and yellow categories. Then before I present the death order data from the PIP program, I just want to show the slide from the soon-to-be published Saving Babies report, just showing the shortfall between our DHIS and PIP data, as you saw in the comic report. So data is not perfect, and it's best to look at trends than actually on the absolute values. Significant efforts have been made to improve the data accuracy. And as you can see, the best performing provinces here, probably the Eastern Cape, Free State, Limpopo, and the Western Cape. From the PIP data set, you can see that the neonatal mortality rate for all deaths above 500 grams was at 10.7, and in 2023, 11.7 per 1,000 live births. And of particular concern, as you can see, is the extremely low birth weight group, with nearly 1 in 2 patients dying, and then also at risk, the very low birth weight babies, with nearly 1 in 5 not surviving. Neonatal causes of death, when you exclude the extremely low birth weight groups, include prematurity at 40%, then infection, which is on an upward trend, and then birth asphyxia and abnormalities at 14%. And then we've also noticed the alarming trend in congenital syphilis. So patients dying of syphilis is not that many, but we're seeing it much more commonly in our wards. I just want to highlight a few of the modifiable factors, and remember that this is for stillbirth and for neonatal deaths. Most are coded as being patient-related, followed then by medical personnel and administrative factors. And I quickly just want to touch on this because Dr. De Waard might also refer to this, that most of the patient-associated factors are still due to inappropriate response to poor fetal movements and delaying in accessing care during labor. And then also quite concerning is patients not booking for antenatal care at all or coming to the clinic at a very late stage. Among medical personnel associated factors, as we've seen, the nosocomial infection is definitely very concerning. In my experience, to try to code for administrative factors are actually quite tricky, and I think this is largely underreported. In red, you can see all the factors that have to do with facilities, NICU care, not having enough beds, etc. We know that there's been a long-standing problem with EMS and transport services that severely limit our interventions in yellow, and then the insufficient staff remains a huge issue, and I think this is largely underreported. It's probably just the tip of the iceberg. When we discuss the recommendations and solutions, there are a few genuine surprises. Although there are robust and very well-designed policies already in existence, it's the consistent implementation and the long-term sustainability of these measures that continue to hamper our maternal, perinatal, and neonatal mortality. So it's something that we have to give attention to. Since its introduction in 2014, the Happiness Framework has continued to provide a structured and comprehensive approach to improving the quality of care, especially for newborn babies. Strengthening the health system and investing in human resources remain critical for our service delivery, and then to continue training our nurses and doctors in obstetric neonatal emergencies, as well as the best possible care for newborns, are crucial to decrease the morbidity and the mortality that we can see from asphyxia, prematurity, and infection, which, as we've seen, are still our big killers. The easiest solution, or the lowest hanging fruits, includes still upscaling antenatal care, administering corticosteroids for lung maturity, and then prevention of hypothermia in the newborn. CPAP and exogenous surfactant given within the first few hours of life, also very important to decrease our deaths in the early neonatal period. And then again, the theme of sepsis, preventing and managing sepsis adequately, together obviously with antimicrobial stewardship programs. As always, breast milk and KMC promotion continue to be central components of our neonatal care. So the WHO recently updated their health policy with recommendations for the management of low birth weight and preterm infants, providing a valuable resource if you want to look at a policy. They basically highlight three key areas, namely preventative and promotive care, care for complications, and family involvement. And you will see that the themes that I've already discussed are sort of listed in these big blocks. There's also a very important shift towards family-based and family-centered care. And in fact, this is the clinical practice guideline from the WHO, and it's hot off the press. It was actually published this month, giving us a comprehensive guide on KMC, what it is, how to do it, and how to implement it actually from birth until discharge of the mother and the baby, and how to support the mom going home. So it's important to know that there's a global call to embrace the zero separation philosophy. So unfortunately, I think the public and even the private sector are very far away from the modern trends in neonatal care, which aims to keep the mom and baby dyad together from birth until discharge. As you can see in these pictures here, given even ventilation and CPAP on the mother's chest. So what is the solution? The answer is quite complicated. So we need to implement the neonatal survival strategy, and I want to sort of explain it as spinning a web. At the center is service delivery, which has to have very strong and stable anchor points. So political commitment, adequate financial resources, accountability in leadership, which is supported by reliable data, is important. Increasing bed capacity and staffing, and then hopefully with the publishing of the neonatal guidelines, there will also be consistency in care that will benefit our small babies. So with this in mind, I want to encourage you to do what you can to advocate for your patients and to put policies and plans into practice and go over into action. Ultimately, our shared mission is to give each and every neonate and infant the best possible start in life, and not only to survive, but actually to thrive. So thank you very much. That is the end of my presentation.
Brilliant. Arina, thank you so much for getting through that huge amount of content and keeping to time. That really is very impressive. I think that picture of the spider web of the keeping the happiness tension, I think that really is very powerful. Please will you just see if there's anything that's coming up in the chat, if there are any questions there for Dr. van der Bijl. While I invite, sorry, Liesl, we've put you under pressure. Liesl De Waard is an obstetrician gynecologist from Tygerberg Hospital. Going to be talking very briefly about some of the trends in stillbirths. We've seen some of the data and some of the trends. Liesl, we're going to give you a couple of minutes to chat about your impressions of the takeaways and the interventions that you feel are going to be most valuable. So Liesl, over to you. Thank you.
Okay, thank you, Dave. Just confirm that you can see my slides.
Yeah, we can see. Thank you.
Thank you. Yeah, so I think, as you said, so good morning and thank you for the invitation. I'm Liesl. I'm an obstetrician working at Tygerberg Hospital, and I'm also a member of the NPEM committee. I think most of the things that I want to say have been covered by this the session in this morning. And thank you for all the other speakers. I was hoping to do some admin, but then it was too interesting, so I had to I had to listen as well. So just to highlight a few things regarding stillbirths in South Africa. So this is just a background of the definitions that we use in South Africa. We include births after 26 weeks or fetuses, babies, and then the WHO defines a stillbirth as a baby who dies after 28 weeks of pregnancy, obviously before birth. So why should we talk about stillbirths? And this is sort of, I think, the question, why should we talk about stillbirths at the Child Health conference? And I think as some of the previous speakers mentioned, this is actually the biggest contributor to the loss of life. Almost 20,000 deaths in South Africa annually. And it makes up 2/3 of the perinatal deaths. And it indicates not only our antenatal care, but in many cases, more the social determinants of health in the communities that we serve. And I don't know if you've seen these recent publications about the stillbirth crisis and also the major gaps in data that the previous speakers also showed us. So these are the numbers of stillbirths in the different provinces, just the absolute numbers, not the rates. But it just shows you sort of the burden of the disease and the loss of life. And then these are the rates in the country. And the main thing that this slide shows is that we haven't really been able to do much to improve these rates as a country or as provinces. And it's just remained sort of very much at the same numbers. You can see here at this bar in orange, almost 20,000 stillbirths per year with small variations from year to year. So the slight variations in the provinces, and I think it just shows sort of more the general health and the social determinants in those provinces, with the more rural and underserved provinces where there are less healthcare workers and facilities with higher numbers. Where do these stillbirths deliver? So you can sort of see the line in yellow are the number of births, and then the dark columns are the stillbirths, and it sort of appropriately shows that there are more stillbirths at the higher levels of care, which is what we want. And then regarding the stillbirth rates in the different weight categories, again, like Arina also showed, in the small babies, obviously the survival is very poor, and there are many stillbirths in that weight category. And then it decreases with our sort of term category of 5.8 per 1,000. And then sort of the proportion of the total is about 2.2% of all the losses, and then again, as we said, 20,000 all the deliveries. So sorry, this is a busy slide, but the causes of death in the PIP data, we don't distinguish between stillbirths and neonatal deaths, but they do add some numbers for the neonatal deaths. So I tried to just look a little bit what is the biggest contributor, and obviously there's a large number of intrauterine deaths that are unexplained. And I think our first speaker that shows some promising information from their study in how we can gather more information on these deaths. Then hypertensive disorders remain a major problem, not only for stillbirths, but also for maternal deaths in the country. Intrapartum asphyxia, as you very well know, is unfortunately still a big concern and also a major contributor to the term deaths. And here you can see that more of the deaths occur after birth, but there unfortunately are also stillbirths from this cause. Abruptio placenta, another major contributor to stillbirths, but also to maternal mortality. And then syphilis, you can see there's obviously a larger proportion of stillbirths from syphilis than neonatal deaths. And this increase in syphilis deaths is also a concern, not only in South Africa, but shown globally, that this continues to increase despite the fact that it's actually a treatable condition. So in terms of primary causes, it looks very similar, above 500 or 1,000 grams, just with the asphyxia causes being more common in the bigger babies. When we look at the modifiable factors, Arina also showed most of these, and the majority are patient-associated. Poor response to fetal movements, late booking, and no antenatal care. The health system issues, I think we are all familiar with: staff shortages, delays, and then medical personnel, medical management, no response to hypertension, delay in referring patient, and fetal monitoring problems. So in terms of our comparison internationally, South Africa, obviously we do far poorly than the high-income countries, and we have a long way to go. What can we do to reduce these deaths? Asphyxia deaths, we need to improve our interpartum management, infection, syphilis. We have increased from these findings our testing schedule during pregnancy with basically monthly testing to identify and treat syphilis. But for this, we need pregnant women to attend antenatal care and to book. Enhance our CTG monitoring and training regarding CTG monitoring and interpartum care, and then really address staffing, transport, and equipment gaps. The other big concern that the previous speakers also spoke about is the improving our data accuracy and capturing. So 20,000 stillbirths a year is really a public health emergency, and there's been no improvements in 8 years. And over half are linked to modifiable factors. And we really need to all work on improving these deaths. It affects the lives of the families involved. So ultimately I thought, what do I want the child health healthcare workers, what can you do to improve these? Remember that the children with medical diseases or conditions that they live with will also become pregnant. Contraceptive counseling for adolescents. When you see mothers in the kangaroo care, again, talk about contraception and birth spacing. We know that spacing the births will improve the outcome of the next pregnancy. Talk about attending antenatal care, and then be involved in capturing the data, attend the meetings. I think we really need a combined effort to make a difference. Thank you.
Things to strengthen, to improve, and to standardize. Definitely some takeaway messages for all of us there. Thank you for that. We will definitely want to share these slides within the child health community. Those of us who work across pediatrics as well as neonates, there's a lot there that we can take away. Thank you for that. That's sobering reminder of the little amount of progress that has been made, and some suggestions of things that we can actually do to do this better. Thank you for that. So I want to hand over to our last speaker for this part of the session, Dr. Sithembile Dlamini-Nqeketo, representing from the World Health Organization, speaking about the transition framework. I'm going to let you unpack that and explain to us what that entails and how that affects us here in South Africa. Okay, we can We can see your slides. If you want to put that in presenter view.
Thank you. Thank you. Am I audible?
We can hear and see you. Yeah. Keep your camera on so we can engage with that. Thank you so much.
Okay. Thank you.
And I'll start the clock. Take it away.
Thank you very much for this opportunity, especially the conference organizers that have invited us to share this. And I must say what has been said by previous speakers really resonates well with what we are about to be talking about. Now, okay. So what I'm presenting to you today is the maternal, neonatal, and stillbirth transition framework, which is a practical guide and process to drive change for maternal and newborn and stillbirth mortalities using the primary healthcare approach. So the targets have been mentioned by previous speakers that we aim to achieve maternal mortality that is below 70 and also neonatal mortality that is below 12,000. Sorry, that is below the 12,000 per 1,000 mark. 12 per 1,000, sorry. So how do we get to these targets? There are implementation packages that we are already familiar with, and they have been mentioned by previous speakers, where we have the 90, 90, 80, 80, 65. And these are the pillars that really will take us to achieving the intended targets. And that includes the 90% ANC coverage, the skilled birth attendance, and up to the last one, which I would like to emphasize, and it has been mentioned previously, the importance of looking at the social determinants that actually help us to know but also to understand how better to improve the health system so that we continue to reduce the morbidities associated with some of the conditions that are seen in the health sector. And we know that there's normative care across, and also we need to know how to manage the complications, which starts by on-site management, but also quick referrals to the next level of care if need be. And also assessing some of the others, the emergency access as well, but also the importance of decision-making, which is the social determinants of health, because that is informed by a number of variants under the social determinants. Level of the mother's education becomes very key. Her nutrition status is also very key. Early child marriages are some of the key that we don't normally mention when it comes to the health sector, and yet they play a pivotal and key role towards achieving the other targets. So WHO came up with the transition framework, and I'll just take you through what it is, but also why it's important for us as a country to consider the use of the transition framework. So the transition framework, the WHO pulled data from multiple countries, over 150 countries globally, and a systemic approach was used and a process was used. And here there was a view of the characteristics of countries that had made progress across several thresholds or cutoffs of mortality. And also they looked at what are the key interventions or priorities that need to be put in place by countries so that they move across the phases. And you will notice that from phase 1, those are the ones with the high mortality rates, and phase 5 is beyond the SDG targets actually, and that is what we all aim to achieve. But phase 4 is when the SDG targets start to fall in place. But ideally, and for the stability of the health system, phase 5 is what we hope countries will all push themselves towards. So to inform those different color codes or the phases, the 4 pillars were used, which is the programmatic choices that countries use, the health systems, the community enablers, as well as the multi-sector enablers. And across that, those were further broken down into what you see there. What is essential is that there are different layers into us making sure that we get, we move forward and continue to reduce the morbidity and the mortality associated with what we have in the health sector as countries. So for those decisions to be made and the cut off, some strategic assessment was done, but also strategic choices also had to be made across the different components of the transition. For example, when you see countries in phase 1, These are countries that have weak systems, and you'll find that availability of the health services at primary healthcare level are not of the standard or the quality that is required. Phase 2, you start to see that the quality improves, coverage also improves, and countries are moving towards the UHC component of it. Phase 3 countries are ones that have scaled up the primary healthcare component, and they are starting to set up or strengthen the secondary and tertiary access and care that is available in those different levels, so that nobody's left behind, but also the services are readily available when needed. Phase 4 are those that have really worked hard towards the UHC. They have stable primary, secondary, and tertiary system, and there's good access to specialized care. While phase 5 is when countries that have already reached the UHC of all the levels of care, and there's ongoing improvement and of the specialized services. So under all those phases, then for you to move to the next phase, there are strategic choices that need to be made by countries. For phase 1, for instance, you need to create demand so that the community understands what services are available, and I trust the system that the system will really take care of their needs. Phase 2, again, phase 2 strategic choices, for example, would be improving primary healthcare packages of care, increasing coverage, and increased utilization by the communities, and systems capacities continue to improve. So I won't read all of them, but basically it has to do with those systems, the quality of services and packages that are available, but also their accessibility to the public. And this starts from primary healthcare right up to secondary, tertiary, and even specialized care. So why would we want to use the transition framework? And I'm happy that the previous speaker have all mentioned some of these points. We need to assess where we are as countries, like individual countries need to assess where they are in the mortality transition, so that you know what to look at, but also review the characteristics of each component by phase. So at country level, we need to do that as well and see what are the characteristics of the country, and so that we better understand why we are stuck, if we are stuck, and how do we propel or push ourselves to move further to the next phase or move faster to even the next phase. And I must say, countries can move from a phase 3 and move to a phase 4, for example, if the systems are really built up and a lot of improvement is made. We also countries need to make strategic choices and also prioritize evidence-based approaches so that they are able to move to the next phase. At some point, other countries will need to review strategic documents so that it's aligned with the evidence base that we have alluded to on the previous point, and then start to close those gaps and rebuild the system. And then the next one, we may need to refine or update our strategic plans, strategic documents, so that it addresses the priorities that countries have made and know that that is what will advance them to the next phase. Building partnerships across programs, but also within the health system, looking at other clusters and other programs, engaging communities, and also engaging other sectors, as well as sharing learnings, both subnationally, nationally, and actually even in the communities. So here are some proposed integration opportunities that the health sector can make. There can be the programmatic integration, where we involve the program review, the multi-year and the micro-planning, then the health systems integration, where other programs I've engaged. We've mentioned the HIV program. STI programs are one of those that are very important for us to work very closely with, so that we continue to lower the morbidity and the mortality associated with. Then the definition of health packages so that we achieve UHC, and those packages must be of quality. The health sector workforce is very important, as they are the ones that render the services. They need to be competent, they need to be confident, they need to be equitably distributed so that access is there. And then finances, is what really drives some of all these resources that we have. Community and multi-sector integration, equally important, because that helps all of us to develop the plans that are necessary to achieve the intended goals. Environmental issues need to be addressed. Emergency preparedness also needs to be engaged and addressed. Nutrition of the mother is important, because that predetermines the outcome of the baby as well as community voices also need to be heard, because that's a feedback back to the health system, so that we continue to do well. but also governance and leadership becomes very critical across all sectors that are needed to make the necessary progress. From the WHO perspective, there's the transition framework that we are discussing very quickly and briefly today, which helps us to know what phase we are using the local data, but also how to take us to the next phase. And then there's the programmatic guide tools that are available. These ones help programmatic level planning, but also integration, identifying the gaps, but also seeing what recommendations need to be made in order to propel forward. And lastly, and the most important, is the health facility, because those are the ones that are the frontline workers, but also work directly with the communities so that they know what the system can offer, and also deliver as the system defines the quality of services and packages that are there. The principles of the transition framework is that it has to be led by the national ministries of health, but engage very relevant and key critical stakeholders, including multi-sector partners and other sectors. And then also to mobilize the broader political will, because we understand some of the issues we are discussing here are beyond health. And for us to move further, we may need to engage other sectors, education, for instance, roads, for instance, so that as we do to minimize the delays from the road infrastructure, for instance, so that we really make a good we move forward. And then engagement and this engagement of subnational and national levels, and these tools can be applied at all levels, really. For health facility care, when you do your own internal assessment, and that cascades up to the national level, the use of credible data becomes very important. And I've heard previous speakers talk about current reports, recent reports that we need to see the data on, so that it tells us where exactly we are and what are the improvements that the countries need to make. And then really this helps countries to develop precursors on the improvement plans that they may have in order to improve the strategies. This obviously will be followed by the implementation of them, but also aligning them with the resources that the country has. There are 5 steps that are involved. I will just quickly go through the major ones. The transition assessment, this is where we look at the national data and subnational data, and we see what the data is telling us. We use the credible sources that the previous speakers have mentioned. And then also step 2 includes mapping the problem. Now, what is the data telling us, so that we better understand what we need to do to move to the next phase. And then from there, there's the assessment of the priority strategic choices. There's a lot that needs to be done, and we've all listed them. But sometimes you need to make hard choices and prioritization so that we have maximum input with the limited resources in an overstretched health system in order to reduce the mortality. Then we need to map those priority strategies and then start planning and resource mobilizing and doing the accountability piece. And this is where, if necessary, we do involve other sectors, education if they are key, agriculture for the nutrition component are just some examples that we may consider so that we can move forward. So when we looked at the transition framework for South Africa, these are the cutoff points. So what we need to do, we split the cutoff points for maternal mortality, neonatal mortality, and the stillbirth mortality. And we're using calendar years in this case, and we use data from 2024 because we're still waiting for the department to officially release the other reports. And I think some speakers have already mentioned that those will be released soon. So when it comes to maternal mortality, for instance, the maternal health we know is equally important to the outcome of the baby. So for that one, the country is sitting around 100, which places South Africa at a phase 3. And then phase 4 is where we see the neonatal mortality. It was also alluded by previous speakers. Where we're not doing very well as a country is the stillbirth mortality, and the previous speaker just alluded to that. And the scoring or the phasing is an average score. So even though we've done very well as a country with neonatal mortality, in principle, South Africa remains at a phase 3 because that gives us an opportunity to identify the strengths, but also look at the opportunities that we need to move forward to the next phase. So this is just, I'll rush through this, is some of the tentative data we've used, where we even drilled down to the sub-national level, and these ones will be best shared by the national department. We were working with the department when it comes to that. So when we break it down with the neonatal deaths and also the stillbirths, this is what the country is looking like with the data sources that are available at present. And then this is some of the stillbirths when we disaggregate according to the weight bands, which is what the data in South Africa is captured. And then problem 3, we use reports that the country is using. The Saving Mother and Saving Babies reports is what we use to map the problems in the country so that we see where we are. And also it's also divided according to the key pillars, the mobility, the coverage issues, program issues, communities, the systems issues, as well as other sectors that may need to be involved going forward. These are the strategic choices that some of them have been mentioned, and even previous speakers have mentioned this. This is still work in progress, and with time, the country will be consulted accordingly through the National Department of Health. Then we come up with a strategic map for South Africa, and then summarize the plan, and this is what is presented and used to mobilize resources and also work with other programs. Thank you.
Thank you so much for that amazing overview of something which is quite new. A lot of us haven't heard of that before, and it's really interesting to see how those parameters are being benchmarked and how we compare internationally. And quite frightening when you show that slide of the different provinces. Lots and lots of yellow, not a lot of green for many of those metrics. Where can we get hold of this document? You mentioned there is a Lancet publication. Is that available from the WHO website, or could you post a link in the chat that we can actually look at some of the resources around this?
I'll definitely do that. I'll share the resources that are readily available.
And it'd be interesting to see how we compare to other countries. I'm kind of looking around at what we're doing with our resources. How effectively are we actually using that?
Yeah. I'll definitely share.
So there's a question in the chat which just says the importance of sustainability of our long-standing audit programs cannot be overemphasized as we engage with the transition framework. DHIS measures still with more than 500. Transition framework uses WHO cutoff for more than 1,000. Without PIP data, we cannot measure ourselves against internationally set standards. Yeah, I think that is a very valid point. Anything that you'd want to add to that, Dr. Dlamini?
Yes, I would actually say the tool is quite adaptable in the process. One of the areas that we had to get clarification on is exactly that, the weight bands versus the gestational weeks, which is what WHO measures. We are adapting it to the local context, because what is important is for it to be usable at local level, which is in this case in South Africa. So that we are being assisted to adapt it for the way South Africa has or is recording its data points, basically. So it's adaptable in principle, but it takes a bit of work to make sure that it's relevant for the country, but also can be comparable with other countries. But it's doable.
Yeah, that's brilliant. That's great that we've got this framework that we can adapt for our own local context, and then work towards that. Exactly. That really is amazing, and nicely we can track our progress and see how we're doing.
Yes, definitely.
Our baseline.
Yes, and it's even applicable at sub-national level. So districts can do this for themselves, and then it can cascade up to province as well as national.
Brilliant. Absolutely amazing. Please really put the link in the chat. I'm very keen to see that. I see there one or two other questions, other two comments. Some people have raised their hands. Folks, please really add those questions to the chat. We're going to take a 5-minute break now. We've a lot to think about. So let's take a 5-minute break. And then we'll reconvene, should we say a 7-minute break, and be back online at 10 to 12. So take a break, go boil the kettle, and we'll be back at 10 to 12. Don't switch off your computers, just leave it ticking over. Please put your questions in the chat, and then the panelists and the speakers, please can you watch the chat and then respond to some of the questions that have been posed. So that ends the first section of our opening session. Thank you very much to Professor Ziyaad Dangor, Dr. Jaco Murray, Arina van der Bijl, Liesl De Waard and Sithembile Dlamini-Nqeketo. Really appreciate your time and investment. I'm sure I've been rushing you, so you're going to grab a cup of tea. Let's be back in 6 minutes for the second half of the session at 10 to 12.